privilege to have this doctor on. He comes in from Cleveland, and his name is Dr. Ogunlesi, who is this gentleman right here. Ken Frame, who is you're the chief nursing officer, Ken, right? And you've been on the show before.
Yes.
And everybody knows Michael Habowski, who's CEO and president of ACMC. Ironically, last week when Mike was on, I asked him about Ebola, and he said, "Oh, yeah, absolutely, we're on top of this thing. We're studying it and been aware of it." And Elaine, who books our shows on every other Tuesday, Elaine Christians, said, "Hey, Pat, we have a doctor that is a specialist in this, and would you like to have him on?" I go, "Right now, I'd love to get him on the show because there are so many people worried about this Ebola situation out there." Doctor, welcome. And can you answer a couple questions that I have on this? Where did it come from?
Well, nobody can say definitively where Ebola comes from, but the thought process is that Ebola was contracted through bats in areas like Liberia. Now, Ebola was first discovered in 1976 in what is today called the Democratic Republic of Congo, and it is thought to be due to contact with animals that is called traditionally bushmeat. Now, currently there's an outbreak in the Democratic Republic of Congo that started in August, and the source is believed to be a woman who processed what is called bushmeat. So they have about 70 cases and about 40-something deaths. So that's the same thought process that while hunting bats, in the case of Liberia, people came in contact with this virus, and that is how, that is the source.
Some lady called in the other day and said that they eat bats and other animals, was it bats and rats maybe that carry this? Is that how it is?
Well, it's thought to be secondary to bats. That's the thought process.
Okay.
And the genetic analysis of the Ebola virus in West Africa is 97% similar to the most recent outbreaks in Central Africa, like Uganda and Gabon. So that's why it's thought to be secondary to that.
Now, they keep saying on the news that you have to be exposed to bodily fluids and that it's not an airborne type contagious disease. Is that correct?
Well, based on the data that we have from previous outbreaks, now the CDC and WHO has worked with the African countries for decades now. And it is believed that you have to come in contact with bodily fluids. An analysis of the outbreak that occurred in 1995 showed that people that lived in the same homes as patients with Ebola, none of them that came into direct contact with these patients actually had Ebola. And thinking about it, none of the family members of the Liberian patient in Texas actually has shown symptoms of Ebola, despite living in the same house with him for at least a week based on what we know. So you have to really come into close contact with bodily fluids. So the main ways Ebola is transmitted is one, coming in contact with bodily fluids, sweat, saliva, and two, it can occur in the lab if the laboratory personnel don't handle the specimens well. But you really need to come into close contact with the patient to actually get it.
So this caregiver, this Vincent girl that came back to Akron and Cleveland, so she handled the gentleman that passed away, correct?
Yes.
So she obviously came in contact with some kind of bodily fluid, right?
Well, I think the hospital in Texas is investigating what might have happened. The CDC, from what I know, is trying to sort of tighten the personal protective equipment protocols for healthcare givers to make sure that no area of the skin is exposed. So I think definitely she came in contact, but how that happened is still under investigation.
You did not know that?
We do not know that at this time.
Okay. Now you're based out of Cleveland, correct?
Well, I see patients in different settings, in Ashtabula, in Lake County. So.
Do we have other infectious diseases here?
None that I'm aware of, but the infectious disease doctors in Lake County, in Cleveland, Cuyahoga County, Geauga County.
Michael, how do
Yes.
you, what have you done as the boss for ACMC? What are we doing to be prepared for this particular thing? I mean, when we talked, I don't even think that story had broke. Maybe it did.
I think it just had on, when we
Maybe
talked
it
last
just
week,
broke
I
it,
believe it was
yeah.
last Tuesday.
Yeah.
So, Pat, we have, we're always prepared for emergencies. We have a dedicated team with a team leader in the hospital, and we have what's called an emergency preparedness team that we prepare for all kinds of emergencies and disasters, not just infectious ones. But what we did is we just called our team together. Ken Frame here has really been at the point. So my short answer is I said, Ken, I grabbed Ken. But Ken can summarize. We've done a lot of preparedness activities. And again, some of it's stuff that we do all the time. But Ken, if you could speak to what we've done particular to the Ebola.
Sure. Thanks for asking. We've had an emergency preparedness team for years and years.
Mm-hmm.
We've been meeting monthly. We do drill. We go over different policies, procedures, look at what is occurring outside. From an emergency management standpoint, there's hundreds of things to be concerned about. Everything from fires and floods, tornadoes, but there's also infectious diseases to look at. We have definitely turned it up a little bit, if you will. We've been doing a lot of drilling with the appropriate type of apparel. One of the biggest challenges that appears the hospital in Texas had was with putting the clothing on and taking it off, and making sure it was done effectively and efficiently.
You have all that apparel there?
Absolutely,
Yeah? Really?
absolutely. We have everything we need to cover us, to
Wow.
provide care to the community. One of the tricks we've been doing is when we have been trying the outfits, and as a method to test them, we've been using Hershey's syrup. So you get everybody all dressed up, and then you squirt them down with Hershey's syrup and say, now take it off without getting any Hershey's syrup on yourself. Because it's a good way. You can't see organisms. You can't see what's happening. But we do have all the appropriate apparel. We're fortunate because we're an affiliated hospital. So there's a lot of resources available to us. Our colleagues at our other facilities, we have great reserves of supplies and equipment should the need arise, or should there be a need for us to ask for a higher level of care. We're really in a good position for that.
Well, that's great. When Mike said last week that we're aware of this and we've been on top of it, it kind of gives you a sense of security that that we didn't have that when that story first broke, because they just kept sensationalizing it on the news. It was over and over and over again.
It is.
And it got to the point where I was turning it off because they were repeating themselves so much. One other question that we frequently get here, have gotten, and you can call in if you have any questions, 593-7181. How do you fight this, doctor? What do you do for it, and what are some of the symptoms also?
The main symptom that we use in the screening tool is fever. And the temperature is 101.5 degrees Fahrenheit or 38.6 degrees centigrade. So people with Ebola tend to have a high fever. And also they have other symptoms like headaches, they may have abdominal pain, nausea, vomiting, diarrhea. So those are the typical symptoms. Also symptoms of viral disease like muscle aches and pains, fatigue, malaise. So those are the main symptoms of Ebola. Yeah.
And then obviously it can be fatal. So what does the organs start shutting down? Is that what happens?
Well, usually what happens is when people have Ebola, I think part of the problem in some of the African countries is lack of appropriate supportive care. Someone that has something like nausea, vomiting, diarrhea in a setting where it's hot, they may get dehydrated. They may have imbalances of their electrolytes, and sometimes part of the problem is those issues are not addressed, and that could also lead to death. Another thing that happens in Ebola is that some patients may have a higher viral load, copies of the virus in the system. They tend to do poorly than those that have a lower level of virus in the system. So things like that, if you don't control the electrolytes, that can affect the heart, it can affect the kidneys, and if we were able to do that, then it's possible to reduce the risk of morbidity and mortality in those patients.
This girl that came back, I don't understand that, and maybe we can't answer it either, but I don't understand why she was allowed to travel.
Well, the issue with travel is policies concerning restrictions always evolve over time.
Mm-hmm.
Now, this is a trained nurse who takes care of an Ebola patient. Usually, I don't think the policy is to restrict travel in nurses that take care of Ebola patients, as long as they observe the protocol for personal protective equipment.
Mm-hmm.
So, she didn't have any symptoms from what I've gathered, or any symptoms that, prior to travel. So, there was really no restrictions on her travel. If we were to implement travel restrictions on every nurse that cares for an Ebola patient, the point is maybe you can't quarantine them for 21 days. You're going to run out of nurses. So it's a lesson that we've learned. And if you look at the Ohio Department of Health, there are certain restrictions that they're now applying to people that may have been in contact with an Ebola patient. So prior to that, I don't think there was anything in the scientific literature that supported restricting her travel.
Yeah, that you're right. You would be running out of nurses if you had put them for 21 days, and that is the time frame, right? 21 days. One of the questions I have here, Doctor, is we're at a desk that is used constantly every day with a lot of guests and that, co-hosts. And what if somebody should like sneeze or something on this? There's bodily fluids involved with that. Would this be a receptacle for that type of thing?
Well, if a patient with Ebola should discharge bodily fluids, it's possible for the virus to survive for a certain number of hours. So that's a possibility.
Really?
And the treatment, of course, is just to clean the surface, and there's a protocol for that, which is part of the guidelines that we follow.
Okay.
So it's a possibility that Ebola can be transmitted through what we call fomites. There was one case in the 1995 outbreak that the only possible explanation for how a patient got Ebola was because she used a blanket by another patient that had Ebola.
Really?
Yeah, so that's a possibility. And that is why, as part of the protocols for handling Ebola patients, we make sure that there's no carpet in the room, no drapes, no upholstery. We're very, very careful about that. So it's possible for the virus to be transmitted in that fashion.
Isn't that what Frontier did? They removed carpeting and they, scrubbed
The
their
airline,
their airline. Yeah. So that makes sense.
They also took it out of commission
Yeah.
for now, temporarily.
Yeah. What was kind of weird about that too, that plane actually, I didn't realize this, but planes fly 20 hours a day. And there was like, how many flights probably 4 or 5?
4 or 5 on the same plane.
On the same plane. So, but they cleaned it 4 times, so I would imagine, see, I was kind of thinking maybe they would scrub it for a while and leave it, not scrub it, but to set it aside for a while and not use it, but they did, they used it, so. I don't know. I guess I'm just a nervous wreck about this thing. It bothers me. I wanted to mention, Ken, you mentioned briefly at the beginning of the interview tornadoes, and you mentioned some of the other things that you have on your plate. Specifically, what do you have for tornadoes in case people get hurt in them and turn it over to you.
We have a lot of things in place for any disaster, any natural disaster that might happen, whether it be a tornado, a flood, a fire, severe power outages. There's a lot that can happen that we have to think about all the time. What can go wrong that would impede me from providing care to my patients? So you have to think of everything from the power plant shutting down, to there being no water, to the river rising 20 feet and knocking out things. We have a number of policies and procedures in place so that we can get help from the outside. One of the things we've learned from Katrina was the development of a system called HICS. That's the Hospital Emergency Command System. And it's a methodology for us to really take control and command and to really run the business effectively to provide the care to our patients, because that's really what it's all about. You know, every time there's a challenge, we need to do a workaround. If there's no power, how do we get around that? Well, we have emergency generators. If there's no water, how do we get around that? We hold enough water on house in our campus to keep us for 3 days. We keep food for 3 days so that we can survive without help from the outside if we have to. It would not be as comfortable, but we could. And that's some of the thinking you have to go through that we have been doing for a number of years. We continue to refine that, and I'm happy to tell you that the government's got a number of wonderful programs for us through FEMA that we actually send people to Alabama for training, and it's a very high level, it's a wonderful opportunity for us.
Yeah, yeah. And you mentioned Alabama.
It's in Anniston, Alabama, and it's an old Army base that has been converted for this purpose.
Really?
And every week they fly in about 200 people from various parts of the United States to learn how to do this. The thing we've learned about emergencies and disasters is Mike might not be there, I might not be there. Who's going to take charge? Who's going to give direction? Who's going to know what to do to ensure that we can take care of our patients? The way to do that is to continually train and to develop a system where rank doesn't really play into it. It's who can do the job. I was saying earlier that, you know, we're fortunate because we are part of a larger health system. They too have resources. They too are tied into hikes, and they can come to our help should we need them. You know, the possibility of us having a problem in Ashtabula possibly would not affect the rest of our system, so we could get help from them should the need arise.
Right. Quick example is, I remember this, we were doing a drill and we said, okay, 3 days of water,
Yep.
we're out. And I remember getting a call saying, hey, we can have a 2,000 gallon tanker from our system, our affiliates. Well, we can have a tanker up in, you know, less than 24 hours. So it's those kind of resources that are really tremendous for us to have.
You know, Mike and Ken, as many times as I've interviewed you guys and other medical staff members from your facility, I never thought of this. I mean, I never thought of what could go wrong. I mean, you just assume that you're going to take, but you have to plan, and you have to be ready for any scenario there.
Absolutely.
It's amazing what you have to plan for. We are looking at 8:46 as we head towards the top of the hour. We just have a few more minutes to go, and so time is running out. If you do have any questions for the doctor, I think a lot of people are just listening to see what has to be said about this. There is a scenario out of the Cleveland Clinic that I was sent the other day, and they mentioned that they asked family members to accompany a patient that might be looked at for this particular disease to go to the exam room with them. Why would you allow that? Is there a reason for that?
Well, the only reason why you allow a visitor in with the patient is if the presence of that visitor is critical to the patient's well-being. Otherwise, you're going to restrict visitors. So under that scenario, you can allow a family member to come in, but of course, they have to take the right precautions before they come in. Because if the patient has Ebola, then that family member needs to be quarantined.
Yeah, yeah.
But if the patient's family member doesn't have any symptoms and doesn't have any contact, and the patient wants that person to come in, then you can allow the person to come in after taking the right precautions. But it has to be very, very limited, and that's the most important thing there.
Do you see regular patients, doctor, or do you just do specialty work?
Well, I mainly see infectious disease patients. That's what I typically see. Yeah.
And can you kind of, because I'm curious, and I'm naive about this, I don't know a lot about it. Can you tell us some of the other diseases that you handle?
Well, I handle HIV.
Oh, okay.
I handle skin and soft tissue infections, lung infections, blood infections, bone infections.
Oh, okay.
All kinds of infections.
Yeah.
Lyme disease.
Lyme disease.
Yeah, Lyme disease. So
do you have a lot of cases with that?
Not too many.
No.
Not too many cases. A few cases from
Yeah.
time to time.
That's the tick, the
Yeah,
deer
tick
tick.
bite, yeah.
I guess Erie had quite a few problems with that this year.
Yes, because people go camping and
Yeah.
get exposed to ticks and all that.
Yeah.
So.
I would like they're going into the hunting season. Would that be a problem for hunters also, even
Yeah.
though it's cooler out and colder?
Well, it's possible for them to still get. Typically, you get it in the summer months, but you know, in medicine we say never say never.
Mm-hmm.
But they just have to keep themselves covered, and if they notice that they have a tick, they need to notify their healthcare provider for, you know, they should keep the tick and send it for analysis,
Yes.
and then we can decide on whether to treat or not.
Okay. Okay. Kathy, I didn't mean to block you out.
No,
here.
that's fine. I'm listening. What do you want our public to know? You know, how worried should somebody be about Ebola? You know, what are some of just the day-to-day precautions that they should be taking or not worrying about at all?
Well, I want people to be calm, right? I think it's very, very important that people stay calm. I believe that the United States has the infrastructure to take care of Ebola. I don't think it's going to be widespread. I think it's going to be limited. So far, we've had just one case. And the other two cases were nurses that took care of the one case. We're putting in place certain protocols to make sure that that doesn't happen again or it's remote. Also, I think the government is screening people that come from areas that have Ebola, mainly Guinea, Liberia, and Sierra Leone. I believe that at the airport they'll probably be able to screen out most. Now, you can't guarantee all. So I think that soon we'll be able to take care of all the Ebola patients we have here. Also, the government is trying to shut it down at the source because that's very, very important. The U.S. military is building facilities in Liberia. They're helping, the CDC is helping in Sierra Leone and Guinea, and also the Democratic Republic of Congo. I believe that once we're able to sort of take care of Ebola there, then I don't expect to see any more cases in the United States. So I think people should be calm and understand.
Not panic.
Yeah, not panic, yeah.
Would you agree that there were mistakes made though in this particular case?
Which case are you talking
With
about?
Vincent, with the girl from Akron, as
Well-
far as CDC or maybe
Well-
even the hospital.
Well, when a healthcare worker gets infected taking care of a patient, definitely that was a mistake made. Where the mistake was made is it's difficult to tell. I think whenever there's a mistake, you must learn from the mistake, and I think that's where the focus should be. Where did we go wrong, so that we can look at things from a systematic standpoint, rather than trying to point fingers at a particular person.
Yeah, and like you say, she's really the only. Was she the only one that got Ebola in the United States? The other ones
two.
were brought here, right?
No, two. There were two nurses.
Two nurses.
There were two nurses that took care of the same patient.
Same patient. Okay. Okay, you're right. You're right. Interesting stuff. I do feel better though that you kind of calmed me down a little bit. What about you, Kathy?
Well, I mean, it sounds like, you know, we catch the flu the same way, you know, and more people die from the flu, right?
Far
Isn't
more.
that?
You're absolutely
more.
right.
Right, right. So, I mean, I don't see why we should be panicking. I mean,
And we have a vaccine for the flu.
Yeah, yeah,
We have multiple
Exactly.
vaccines for the flu.
sure,
yeah,
sure,
yeah. So, okay,
yeah.
we should be able to travel, and you should be able to follow your own precautions that you typically take, and everything should be.
What a
absolutely
medical person the other day said, I think it was on national television, that we really should be more concerned about the flu, because that's what's going to be affecting all of us more than Ebola will. It's like this doc says, it's probably pretty much centralized here, and it's not going to be growing out like that. So it's good to know we got people on top of this story. I appreciate it, Doctor, coming in,
Thank you very much.
and Ken, you too, and Michael, thank you so
Tell
much.
people get their flu shots. I mean, that's one of the
Absolutely.
biggest
Yes.
things we can do right now. So
Get mine tomorrow. Get mine tomorrow. So yeah, very, very important. Thank you, gentlemen, for coming in. I really
thanks.
appreciate it. Thank you so much.